Hello, everybody. My name is Dr. David Fletcher, and I want to welcome you to the Insight Deep Dive. And this is part two of a three-part series, and this one is on EMG. And I'm very excited, really excited to put together a fantastic program because EMG has a very special place within not only CLA, but within the chiropractic profession. I think that you'll really start to enjoy the connectivity that EMG brings, especially when you start to listen in and understand what we talked about in the first of the deep dives, which was heart rate variability. And the other side is to begin to start to understand what it's like to look at muscle tone within the spinal region, not through the muscles, but through the neurological connectivity. And that's what EMG is going to bring us. And that's what we're going to be starting to explore in this particular session. I have a particularly great fascination for EMG because I did a tremendous amount of my early research in physical performance using EMGs, and I'll talk a bit about that. But the energy that we can bring to the table side with a greater understanding of EMG is one of those wonderful connections for the patient that helps them understand how we can literally connect the hip bone to the universe. So without further ado, I want to jump in and start the program. The necessities to keep us focused are that we're going to keep our like in a good research paper, we're going to talk about keywords. So keywords in this deep dive will focus on the motor nervous system. We'll talk about dyskinesis. For those of you that aren't familiar with that, this will be a new but exciting concept. We're going to talk about neuromuscular tone. We'll talk about postural adaptation. We'll talk how EMG signals rely upon amplitude and symmetry. We'll start to look at the consequences of the vertebral subluxation through exhaustion. We understand gravitational load now as it relates to EMG, and we'll start talking about the compensatory effects that happen with that. We'll talk about a phenomenon that as an interpretation towards the EMG, you'll start to get very excited about. This is what's known as the cluttered closet principle. And finally, we'll talk about neuroplasticity. So good and exciting times for us to move forward. It's always wise to remember that we're looking at the central nervous system, and the central nervous system has three divisions. EMG is looking at the tone of the motor nervous system. Now, last time on the first of the deep dives, we started to talk about the global impact of the vertebral subluxation on autonomic tone. And that's why we started to look at the impact and the use of heart rate variability. Well, today we're going to be focusing on the motor nervous system. And there's some terrific understanding and perhaps new ways in which we can begin to leverage that part of the whole discussion. Now, scanning using the instrumentation is and always has been one of the passion plays of CLA. We exist really for one reason, and that's to bring the best level of quantified and qualified technologies to a chiropractic setting. Why? Because we're chiropractors. We understand exactly what it takes to not only have the confidence to have a conversation with patients, but to really focus on making the invisible visible, not just for the clinician, but for the patient themselves. Chiropractic is based upon the simple premise of the innate ability of the person to reorganize themselves spontaneously in the face of performance, in the face of stress, in the face of challenges, and obstruction to that expression of this perfection are what we refer to as the vertebral subluxation. So anytime that we can measure our abilities to not only detect a vertebral subluxation pattern, but also to manage it through a very quantified and qualified care plan, then we have a mechanism under which we can absolutely focus on the greatness under which chiropractic is examining, but also imparting the changes through the adaptive ability of an adjustment. This is a particularly wonderful evolution in the technology. For many of you who understand what was originally known as the subluxation station, it was a wired console that was based upon the EMG, and then there were peripheral plugins like thermography or PWP or otherwise. Well, with the evolution of the wireless neurocore, which is what you're seeing here on the image, we were able to really not only leverage the significant transformation in terms of signal management and the compression of all of the data management, but we also were able very clearly to make it a very portable and very usable piece of technology. There's a picture of me checking out Ayla, who is an age 12 patient, and we'll be talking more about it. But the value of this particular NeuroCore is that it allows the flexibility to bring it from exam room to allow you to put it in the tableside environment. And most importantly, it allows you to have a confidence because it's collecting some phenomenal data streams in an even more capable ability as we leverage things like the Apple processing systems in the new Synapse system. So the NeuroCore is really the next generation of EMG collection, and I want you all to have a great new familiarity with it. It's faster, and its signal processing is superior to anything that is available to chiropractors. So what is EMG? And I think this is really what we really focus on. You'll notice that as I was putting the notes together, that I underlined neuromuscular measure of gravitational response. There is an entire division of your nervous system which is focused on handling the effects of gravity. The autonomic nervous system is associated with regulation. And of course, it interfaces it with everything from emotional tone to the reactivity of the regulation of organs and glands. And as we found out, regulation of everything last time in the first of the deep dives. EMG is measuring a division of the nervous system that is tasked to manage the voluntary activity associated with managing position and motion within a gravitational field. Everything about our ability to perceive ourselves in our environment, to move, to have the ability to function in a motor functional way is controlled through this connectivity. And of course, it all begins in the frontal lobe, where we have this, well, I wouldn't say all begins there. There's coordination of it in the frontal lobe as we start to have the precentral gyrus of the cerebral cortex, which is the motor center within the brain. And it then sends through tracks down to the spinal cord, and we have segmental neurofunctional abilities that are under the control with this reflex loop that I've showed you here. So we have a lower motor neuron connecting into the tracks, and this efferent approach then sends signals out to the muscle spindles and causes contractibility through the actin and myosin connections that are associated within that muscle spindle. Of course, there's Golgi tendon organs, which are watching for stretch responses, and there's a tremendous amount of feedback that's then going through the afferent wing of this. And as we then connect these loops that are associated with it, we have control mechanism of the segmental neurological capacities. But EMG is very complex because there's a lot of muscles firing. There's segmental muscles, there's surface muscles, there's deep muscles, and then there's smooth muscles. And so to be able to understand how we can capture the muscle tone that we're looking for, we have to recognize that there's different forms of EMG, and we'll go into that in a moment. But what we're most interested in chiropractors are the paraspinal, more surface detectable musculature. And the reason is that those really are associated much with the vertebral subluxation, but primarily with the postural shift that has been started. Of course, anytime we start to look at neuromuscular tone, there's what is called crosstalk. And crosstalk has to be filtered out for there to be any level of understanding. So we have a 0 to 500 hertz bandwidth that we measure within EMG. And what you need to understand is that we're primarily looking at the surface, and when I mean surface, we're not looking at the deepest musculature like the multifidi or otherwise. We're primarily trying to look and see where the contractibility is of our gravitational modeling. You see, when gravity is pressing down on us at 15 pounds per square inch, then we have to be able to resist that. And we can't collapse under the gravitational load, nor do we do we become, immobile with it. We have to be able to function and move. And as a result of that, we have to spend neuromuscular energy. And there is a quantifiable amount of tone or amount of energy that has to be spent for us to function in gravity. And so one of the most important ways that we can identify a vertebral subluxation is this overexpenditure of energy when there is a controlled task that is being done. And the controlled task that we have set up in a CLA protocol, which is pretty much the standard now, and I could go into how we were associated with working with NASA as it was relatable to gravitational loads in the early days with astronauts and coming from gravitational fields to non-gravitational fields. It was very exciting work. And what I need you to know is that in the ability of EMG, what we're looking at is collecting what's called static EMG so that we can control exactly this pressure pattern that's coming down in an axial loading way. And we can then measure how the body, in this case, the paraspinal musculature, is supporting up against that gravitational point load. If it is failing, then it means that the muscles are overworking. And what you will learn is that as they are overworking, it is literally like a spigot is open and there is a drain that is taking all the energy, not just from that neuromuscular bundle, but impacting the entire ability of the organism to function, which brings up a very exciting connection with the chiropractic principle of being subluxated, not locally, but when we are subluxated with every cell of our body, with even every atom of the connectivity and the energy management within our body. So we need to have a very sophisticated ability to filter out the noise. I mean, even the beating heart is sending a neuromuscular signal. So we have to be able to detect that frequency range and cut that out if we're going to be able to do it. So there's nothing casual about an EMG signal, and it takes so much engineering, and we're exceedingly proud of the level of engineering. In fact, we're so proud of it that we believe that we have by far the finest EMG anywhere that can be used. So two of the hallmarks that I want you to focus on when we're looking at that signaling in a muscle. Remember, just like we talked about with HRVs, that there are dynamic patterns of wave movements. So wave functions, such as the sine wave, is associated in this case in the motor nerve with causing contractility within a muscle. Well, we can look at that wave format and understand amplitude and symmetry. And from that, we can then begin to score patterns. And it's these patterns that help us detect if a subluxation is in play or not. So it's very important to understand that different iterations of EMGs are available. And what I've done here in this simple chart is separate our salutogenic, which means that we're looking at the promotion of health, versus a pathogenic model, which is the identification of disease states. And when we take a look at salutogenesis, we take a look at the ability to maintain energy. And that's just what I said. We look at surface EMG instead of needle EMG. Needle EMG is used for conduction studies. And this is used in the medical side of things primarily to see if there are damaged conductions within peripheral nerves, especially. And so we would find that in carpal tunnel studies. Static EMG is ideal for looking at this because it's looking at that resting state so that we can then determine if a person in this most controllable, measurable state is actually spending too much energy or if they're in a perfectly well-aligned and well-adjusted state. Dynamic EMG, which has its place within chiropractic, however, is primarily looking at what is known as a flexion extension phenomenon. And unfortunately, it is primarily used in a pathogenic model to try and identify if there has been some type of poor, in this case, lumbosacral reactivity that unfortunately is related more to injurious or recovery states of that one. Again, not that it's wrong to even look at a dynamic EMG state within the chiropractic model, but in a vertebral subluxation model, we tend to focus on the static side. So I hope that adds a little bit of understanding. This is important because you may come across papers of where there is this dismissive approach as to whether or not EMG is valuable in a chiropractic setting. because EMG is really not that good, except in that flexion extension modeling, to try and help us understand if there are pain patterns affiliated with that. We're not that interested in EMG studies looking at pain patterning. We're looking at EMG studies that focus on the ability to manage energy within the entire organism. So I put this chart in because I think it's really cool. I think that many of you who may be Insight clients from the early days might have, lost some interest in using EMG. You might have been focused more on, for instance, HRV or things that were more of the autonomic system. But I need you to understand that when we began this journey, and which is really right up there and about where you see the first part, which is about 1980, 1990s in the CLA side of things, look at the exponential growth of papers that are published each year on surface electromyography. And this is so critically important. This is not general, when I say general, this is not pathogenic myography. This is surface electromyography. Over 700 papers are published annually in this 2020 idea, and this is coming from PubMed. So you are absolutely on the cutting and leading edge when you choose EMG, because you need to understand that all of the data that's coming out is focused now mostly on not only rehab and recovery, but on restoration and resiliency. And this is what comes very, very exciting, because that's our hood. That's what we love to do. So I wanted to begin what we know are the important aspects of looking at the research models as to why you should have the confidence to work with EMG. Certainly, I've given you a tour of what we believe is the best technology that you can use in an EMG setting. But now when we take a look at validity and reliability, we start to look at what matters in terms of your confidence when you do a scan, to know that it's telling you what it's supposed to be telling. Well, validity is associated with the right tool, if you would, to use for the right job. And so we don't use EMG in a chiropractic setting to look at the pain pattern. And many times, unfortunately, the clients or patients will get a scan view and it will show red in areas where they're not feeling pain, or it will show low colors in the areas that they are showing pain. And this can be confusing for them, which is one of the reasons that we've pioneered the use of what is known as a pattern graph. And I'll be teaching you much more about a pattern graph as we go through this whole process. Inter-examiner and intra-examiner reliability is paramount if we're to have a confidence in using technologies, not only in a single use, but also in progressive uses as we begin care plan management. And Dr. McCoy, who you've met through the Foundation for Vertebral Subluxation, as well as McCoy Press, was one of the lead authors in this particular citation. And it became very clear that it was very much an exceptional inter-examiner, intra-examiner reliability. I put this down below it to just highlight that surface EMG has demonstrated very good to excellent. So on a scale of 1 to 100, if you would, or 0 to 1, then what you need to understand is that anything less than 0.5 is considered not very reliable. But when you start to get into the high numbers, it is very difficult to get into the higher numbers in the 0.8s and 0.9s unless there is exceptional reliability. And as you can see, CRAM reported a mean reliability coefficient of 0.83 for surface EMG, and Spectre used a fixed surface to attain this assessed paraspinal activity. And again, we're talking about the 0.83 to 0.9 regions, which should give you the confidence to know that when you use EMG on scan 1 to scan 2 to scan 3, especially with the protocols that we have put in place at CLA, that you are getting true and clean reads between examiners and sessions. So it's always important to remember where we want to understand how a signal is generated and what impact it has throughout the organism. So I put this slide in just as a reminder. A organism, we as people have to perceive ourselves in our environment. And so we have sensors that try and help us detect the physical, the chemical, and emotional stress that come into the control mechanisms of the nervous system. And in this case, when we start to have the nervous system needing to respond, it has to trigger a motor response, which triggers a muscle contraction. The muscle contraction is then triggering an efferent process to where the bone and joint are then engaged. And if we have this bone and joint being placing a disassociation in what are the normal positions of that bone and joint, that is picked up as an aberration by the afferent part of the reflex arc, and this then sends a signal back not only to the local nerve area but also up the tracts and into the premotor cortex. And as a result of that, we have a brain-based functionality. And just to remind you that when we have control mechanisms through the nervous system acting through the active components, which are the muscles, which are then interacting with that passive component, sending back information to the nervous system, we have this closed loop. And this closed loop is known as the vertebral subluxation. So you can see how important it is to understand that regardless whether it was a physical impact or whether it was chemical or even emotional, the muscle tone will change. And we can determine that by observing posture, by measuring EMG signals, by looking at the impact on the overall person as they adapt to their environment with the autonomics, with HRV, and with the thermography. So I think it becomes very exciting to recognize that the vertebral subluxation takes into account the entire central neural processing. And so as we go into sort of the visualization of this, and we'll look at this in just a moment, I put this slide in because what we recognize, and I think this is really important to understand as well, is that we can start to begin to see posturalization, in this case of a sympathetic dominant state. It's very important to recognize that when we overtax or we trip the switches, our autonomic system is designed to identify a threat. And as a result of that, neurotransmitters are affiliated with the fight-flight response. The fight-flight response then triggers that contractibility in the motor nervous system and causes a flexion response to occur. If the flexion response or the outside nauseous impact of those external stressors is not removed or adapted to, then this becomes habituated. Posturalization is a very important understanding within chiropractic, not to look at the simple distortions within the spine, but to understand that if a person remains locked in a flexion state of sympathetic dominance, that eventually structure will adapt or maladapt. And many times by the time we use X-ray to understand how a patient's distortions of the spine are causing them, symptomatology or their loss of function, then we need to recognize this coherence, if you would, between the autonomic initiation of structural degradation. And of course, as there's more structural degradation, there is more of a distorted tone that goes back into the autonomic nervous system. So the interface between autonomic regulation and all of this posturalization, socialization, and loss of flexibility of the human being is observable in the motor nervous system as this lack of posturalization. But on EMG, as I'm going to show you, you are going to be able to track this energy expenditure that is so costly when you have forward head carriage like this, or you have thoracic kyphoses, or even the loss of lumbar tone. So it's very important to understand that the interaction of the central nervous system is not singular. There's not EMG studies, there's not HRV studies, there's not thermographic studies. And that's why we've been passionate for building neural profiles for every patient instead of just taking snapshots of one division of the nervous system. And this is why as a founder of CLA Inc., what we've done is that we've created the Neurotech, which gives you the ability to have a confidence to read each divisional functional area of the nervous system and tie it all together with a core score. So hopefully this is helping you understand the interactions between these different divisions. So I want to now jump into probably the most important aspect of of understanding EMG in a chiropractic setting. And this is where salutogenesis meets EMG. And this is the concept of dyskinesis. What's fascinating about this is that this was posited by two social scientists, Whatmore and Coley. And one of the things that they recognized is that, and I always found that was interesting, that it was behavioral scientists and it wasn't biokinesiologists that were understanding this interactive play and using EMG. They were mostly interested in this understanding of the state of distress that a person was in when they were emotionally and socially not adapting to their environment or to their situation. And so they immediately looked at how they could use electromyographic signaling. And these two were pioneers. This was originally published in 1968 and has been used as a citation for thousands and thousands of articles over the years because it was so revolutionary in the understanding that we didn't have to confine ourselves to the segmental watchfulness, if you will, of does it hurt here or is there this fixation versus subluxation. And as a consequence of that, they use the principle of dyskinesis, which is a reversible physiopathologic state composed of errors in energy expenditure, get this, that interfere with the nervous system function and thus with control of organ function, carrying on, resulting in reduction in the organism's productivity and disturbance of its emotional reactivity, ideation, and central regulation of various organs of the body. How chiropractic is that concept? Is that we have the ability to awaken or arouse innate by identifying where there is an obstruction to the functioning coherence within this person. They went on to say, are you ready for this? Electromyometric studies are a necessary part of each patient workup whenever dyskinesis is suspected. Let me just share with you, dyskinesis is suspected when you take a look at posture. It is so energy consuming to be off your center of gravity. It is so energy consuming to be at stress in your environment. So I hope you fall in love, as I did, with dyskinesis. I think it's really cool to sort of understand that once you gather this idea of the importance of EMG, but this impact of the motor neurology, both internally and externally, from posture to movements. And I have to tell you, I'm in love with posture and movement. I know sometimes it might show that I'm sort of, more focused on the internal conflicted responses of the autonomics. But, I cut my teeth getting into this game as a fellow in the sports sciences. I learned EMG, not necessarily primarily through a perfect window, which was the salutogenic chiropractic model. I've come to love and promote that. But I was looking at performance as I was understanding in these deeper areas. And so it's allowed me to have this really cool interaction with understanding structural performance and kinesiology with the salutogenic responsiveness. Every chiropractor, I don't really care how tilted you are one way or the other, can benefit the patient if they understand dyskinesis as it relates to postural tone and functional abilities within the motor nervous system. So there was a wonderful, again, I'll quote a Canadian researcher out of University of Guelph who came up with a really novel concept. And what they were doing, his whole research was on looking at senescence, which is the expression of life longer, and resiliency within organisms. And he was focused on, if you can understand this, on the impact of the motor, in this case, an anterior motor horn cell. And what he found was, or what they found, was that the tone or the functionality of a motor horn cell was directly related to this senescence, about the length and quality of life that was going on. And of course, you can't necessarily do these lifetime studies in quick order in humans. That would take many lifetimes. So they picked a, quote unquote, in their terms, a mammal that happened to have a very very interesting reaction, but had very large and identifiable anterior motor horn cells. And it wasn't a mammal, it was an insect, but it was Drosophila melanogaster. And this is a fruit fly. And fruit flies, have a lifespan of about 6 days. And as a result of that, you can look at their behavior, but also you can take a look at their progeny and ability to look at this life cycle and life history and who knows, but they're behavioral scientists as well, and look at how they react behaviorally. And it becomes absolutely clear that the health that was directed at the motor horn cells was directly related to this long-term benefit. So put that in your memory hook, and just know that as you clear motor distortions, that senescence as well as capabilities are improving. Finally, I get a chance to work with Edmond Jonquière, who is at the Department of Electrical Engineering at USC. And I was introduced to him through Donald Epstein and the, at that time, Network Spinal Analysis Group. And they've done some amazing work. We donated significant EMG studies, EMG technology, so that they could study the wave format. To put it very simply, Edmund and I understand the science very carefully, but you need to understand that when there are waves that are affiliated with improving coherence within the motor nervous system, that it absolutely impacts the coherence of all functioning cells within the body. So every time you see an improvement or a changeability within the motor functioning nervous system, you are changing the ability of that person not only to adapt, but to live a longer, healthier, and happier life. Very important. So how do we make it usable for each and every one of you? Well, we have to have a normative amount of data, or at least a normative data pool for you to compare against. And that normative data has to be based upon a chiropractic setting. And so two of my mentors, Patrick Gentempo and Christopher Kent, were the ones who originated this study. And this goes back to 1996. So it's been around for a very long time. And I'm very proud to say that with the data that we're collecting now in a cloud-based environment, we're revisiting these normative values. They are incredibly similar to what we're looking at right now, but we will always be bringing our CLA clients the most current levels of normative data so that you can compare otherwise. Anyhow, so what we did was that there were, I believe, 80 to 90 different subjects that were deemed to be in care and well adjusted. And when we, meaning CLA, did a scatter plot on these different regions, it was found that there was a tone and a firing ability at each level when they were well adjusted, and that if they were subluxated, it went outside of that tone. So these are the important numbers that in the upper cervical region, for instance, at C1, you can see that 3.8 on the left and 3.9 on the right. Don't know the reason, perhaps it's handedness or otherwise, that there could be this slight distortion, but we were able to codify 15 different levels and recognize that this normative data was what we could compare your patient to. And that is interesting because we, in this validity and reliability study, had the patient set up so that they were seated, so that there was no movement, so that their hands were placed on their thighs, and so their feet were touching the ground. They were sitting upright but not rigid and looking straight ahead. And in fixating, which is the way you all do your scans every time, you now have a comparative model to allow this to happen. And we found that, in the studies, but also in clinical practice, that anyone over the age of 5 could sit still enough so that we could do these type of studies. And we know that there are examiners who go below that age into the 3-year-old and 5-year-old, and 3-year-old to 5-year-old. And I'm very proud of those examiners because they're very skilled in ensuring that they get good reproducible data. And one of the things that we know is that when you start engaging into the children's side of scanning with the EMG, that you can reposition the child. It's not perfect science, but that you can, if they tend to slump forward or they tend to move themselves off there, you can stop the scan, especially with this new technology, reposition them back to the neutral and continue the scan from that segment upwards. Not that we advise that all the time, but we need you to understand that there is this flexibility now with the NeuroCore technology to be able to do that. And I think that you will fall in love with this vase shape because we're going to show that in the pattern graphs. So Normative data for paraspinal surface electromyographic scanning using a 25 to 500 hertz bandpass shows that we can absolutely pick up these different signaling processes. And remember, as we go through this, that there is this interpretive value of understanding when we compare to this amplitude and symmetry. So those are two very important aspects of understanding the measurement in this area. So to make it easy, what we've done is that we then started to employ the principle of standard deviation. Now, standard deviation is a mathematical process under which we can take the mean, and then what we do is that we take the square root of that mean and allow ourselves to look at variance. And this is a very standard, it's used in investing, it's used in the physical sciences, it's used everywhere. So this is a standardized approach to recognize that we have standard deviations outside of a norm. And that then allows us to quantify whether it's mildly, in other words, one standard deviation out, two standard deviations being the blue bars, one standard deviation being the green bars, slightly out of range, and three standard deviations or above in the red zone. If we have less than a normative amount of tone, we have what is known as a yellow bar, which you can see in here, a hypotonic response. And that becomes very important clinically, because when we understand the clinical application of EMG, many times when we're in a pathogenic model, we're many times drawn to the idea that red is bad and less red is getting better and yellow is, very poor. And to some degree, that's accurate. But when we start to take a look at the necessities of not taking one snapshot, but looking at progressions from initial scan to progress scan to comparative scan to continuation scans, then it becomes highly important to use these different colorations to understand patterns. And we're going to spend some time looking at pattern scores and pattern views in a moment. But this is known as an amplitude view. And what you're looking at is actually a very intelligent system doing the best it can with what it has to adapt to a subluxated response. Somewhere in this chain of communication from brain to body in the motor nervous system, the body is struggling to adapt. And so when we tend to see colors, many times we think, there's the problem. It's palpable hypertonicity. But the truth is like doing this, is that a good thing or a bad thing? We don't know that quite yet. It just means that the body is wanting to protect itself in that flexion responsiveness. And many times when we see the yellow here, it's an indication that that flexion and that spinal posturalization and responsiveness has been going on so long that there's now an exhausted component to it. So it becomes really important to recognize that when we see colorization, is that the body is acting responsibly to protect itself, but it then progresses down into a very flatline response, and that can be very dangerous. We do offer many times on the scans a black line, if you would, and that is over 3 times the activity. Typically, we'd like you to scan within those first 3 zones. So, but unfortunately, many people have that hypertonicity or spasticity that takes them into the black lines. So this is an amplitude view, much like I was showing you. This is a different one. But anytime that we have over 3 times the standard deviation, we will start to get a red bar coming up. And you can see that this person has 17.4 in the upper right C1 region, where it's at 6.2. That's still 3 times up and above, and 5 and 6 times still presenting red. So red needs to be understood that it is very much a hypertonic responsiveness, and you will be watching that on the pattern scores a little differently. The length of the bars is somewhat representative of the amount of tone that's in the system, but there is a limit when we put them on this graphic representation. So again, on the pattern graph, you'll get a much better view as to how much further and farther out the range is than what you'll see even on these amplitude bars. In this one, you'll notice that there's a congregation. The cervical spine is much more in a reactive state. And as I take you down this journey of interpretation and understanding, that becomes important because part of the posturalization process is to be in head forward carriage, carriage in a forward way. And as a consequence of that, the EMG is really giving you signals in the rotatory responsiveness. I can tell you right now that there is a lot of shear forces on the left-hand side of this cervical and thoracic spine compared to the right side. And that's why we have a second graph that looks at this, which is the asymmetry graph. Now, this is not from that same one. I just pulled this one out as a general symmetry graph. But what you can see is that, again, using mild, moderate, or significant, that we start to see that there are significant rotatory shear forces that are applied into the spine. Remember, if the person is bilaterally, symmetrically, hypertonic, that it's neutral, but it's expending lots of energy. In this particular case, in the upper cervical region, you can see that there's a 53% greater shear force or distortional torque that's being applied at C1 when it's compared to its right side and left side. And not surprisingly, the body has to counterbalance that. So you'll see a lot of this counter shear and shear forces occurring, where we start to see torque and counter torque in either segments or regions coming about. This is an important aspect of interpreting your EMG scans on sequential ones, because you want to see less of this asymmetry going on. In fact, you definitely want to see on your pattern scores, as I keep talking about it, as your symmetry scores improving, as we start to see, for instance, this pattern score improving. And again, these strain and shear reactions, and I don't ever endorse this, but they're probably more inflammatory than what is going on elsewhere where the shear isn't happening. And there may be correlation between palpable pain patterning than what we have studied here. But that might be a clinical cue for you if you start to see these high shear responses, to understand that that might be part related to their pain profile or their symptomatology profile. This is the pattern graph that I was talking about. You can see again in C1, and I'll start to talk about this a little bit deeper. In C1, you can see that this is far further out on the right-hand side than it is on the bar graph that I was showing you. And so when we develop a pattern, we're taking data from both symmetry and amplitude at each level, but get this, on the right-hand side and on the left-hand side simultaneously. And so the data plot literally is that we could theoretically just look at one line. We don't want to, but we could look at one line, and the other line symmetrically is then compared. But what we're looking at is the distribution curve of brain to body, body to brain symmetry and coherence. And so if you look behind the scenes, behind the black line, which is the actual plot of the amount of energy that's being distributed in this particular examination, if you take a look, and you'll see that there are yellow vase-shaped lines, that there are white, which are the normative ones that you've seen already, that there are green, that there are blue, and that there are red zones. And you'll notice that this particular patient has their C1 far outside the red zone on the right, but the rest of the areas tend to be in the blue or less. What catches my attention as a clinician is the collapsed signal, especially in the T6, T7 right area. Notice the flat lining that's going down on the right-hand side, and that we have this excessive amount of activity. This is not scoliosis. Scoliosis might be involved here, but typically a scoliosis of where there's actually shift in the postures is not necessarily measured on EMG. We can get compensatory yellow that's going on because of the exhaustion for so many years of that neuromere and myomere that have been under that stress. So please don't read these as if saying that you've detected scoliosis. However, two things, and you can hear where I'm coming from, capture my attention, is the collapsing of the signal in the distribution curve, but the excessive expenditures, as we see at T10 and C1 on the right, to see that we have that T1 on the left-hand side and T6 and T8 on the left-hand side. And again, we come down to a reasonable amount of energy being distributed in through the lumbosacral region. Again, always watching not only for this scan, but where we're going to see them in the future. again, I've talked about this, is that the red is activity significant. The red line is if your black line transitions over top of these lines, then you can look at energy expenditures. What's most important are the numbers at the bottom. And so we've done the calculations for you, and the energy index, which is really the important one, is the total energy that's being expended. It's based upon an index of 100 being normal. I want to share with you right now that our studies indicate that children in the 5 to 16 to 17 year range, but certainly 5 to 13 year range, that index, that energy index, is normal to 125. And so it's important that you sort of put that in your memory hook. We have the energy index being at 144.7 on this particular person. So for whatever they are losing in that T6 to 8 region on the right-hand side, they are overexpending to put them 44% more in their energy expenditure than we would like. Their pattern is the efficiency under which they are distributing that energy. It should be 100, but you can see that they're only operating at 46% efficiency in distribution. That's not okay. That's the one number you're going to be really wanting to watch on subsequent scans. And finally, the symmetry is operating at 55%. And remember, I would like to see, so when you see that symmetry below 80%, be thinking that you're involved with a lot of those shear and torque forces that are affiliated, because it's not symmetrical all the way through these systems. I put this in just to remind you that you always can generate a EMG data table. This comes in the narrative reports as well, and it publishes the standard deviations, and you can look at the plus signs, if you will, beside each of the different segments, and the plus sign of +1 is 1 standard deviation, 2 is 2, and 3 is 3. And so you can see that in a numeric fashion, for instance, if you wanted to send this off in a narrative report to, other clinicians, but certainly in PI work, this is a valuable tool as well. And so one of the things that we always remember is that we're not isolated in using scanning alone. We, myself included, many of us use X-ray to look at the final degradation of that posture and the structure. And so I put this in to remind you that when we see bilateral cervical from C1 to C7 to T2, and we see that bilaterally active like this, many times it's a signal to tell you that that person has forward head carriage. And why do we know that? Because when we ask that person to do this simple task, which is sit upright, I'm doing that right now. I'm coming from my flexed forward head position, and now I'm being asked to sit up to do the test. I have to spend over 3 times the amount of energy that I'm comfortable with to get into that posture. So these are cues and clues to help remind you that there's a lot going on. Now, one of the things that I instituted when I started to teach the clinical application of EMG was to really understand what I created, which was called the cluttered closet phenomenon. And I want to really focus on that because there's a little bit of a misunderstanding when it comes to good and bad in scans. Many times when we do an initial scan, 2 things happen, is that the patient doesn't see the problem on the scan of where their pain pattern is. And I think I've talked a little bit about that. But we're also meeting people that are very much in a compensated state. Many times you will see an underperformance on their scans compared to what their symptomatology can be telling you. And that's not to be judgmental. That's just to tell you that one of 2 things is at play. They're either in a blunted neurological response because they're in a maladaptive phase, or they're taking drugs, muscle relaxants, anti-inflammatories, or others that are inhibiting the neuromuscular response. You can ask them about it, and we certainly know that if we pick up somebody who has a tremendous low starting point from this green or even the yellow, it should raise a flag for you to really ask again to see if they've taken any over-the-counter for symptomatology, anything that is antispasmodic. It could be also that they're on blood pressure meds. Many times blood pressure meds, chronic use of blood pressure meds can again create a lower, even though they're designed to take the load off the heart, they do suppress many times a neuromotor response as well. So again, ask the question, but think about it. Remember, these are palpatory findings at some level. These are great digital examination tools. But let me share with you that we're looking at millionths of volts. That's what a microvolt is. And so you can't palpate, 6.2 or 17.4 or anything like that that's going on in these zones. So I want you to just recognize that when you get scan 2 and you start to see them light up like a Christmas tree, that you've done no harm in most cases, is that it's really associated more than anything with this ability of the body to begin to respond. And we think about that is that many times when we take a compensated person and we begin, let's just take it off the grid in terms of adjusting, but we ask a person to, for instance, exercise. And as they begin to engage in a very positive experience of exercising, it's really about unpacking the old way of doing things and reusing or initiating reactivity of new dynamics, new habits, and otherwise. So unpacking old habits, whether it's in postures or in fitness or in adjusting, demands that the body respond. And the way the body responds very clearly is that it has to use energy. And so often when we go to the gym and we get kind of that burn in the muscles, and day 2 after that, we're like, oh, good, I have a burn. Yeah, I can hardly move, but I know it's a good thing. Think of it in those terms, because what you're seeing is the body is energizing itself to begin change, which you are initiating. So I created this concept of the cluttered closet because so often we'll be walking into an environment of where our linen closet, for instance, works perfectly, doesn't it? Just like this patient on the left-hand side. They're working, I wouldn't say perfectly, but they're functioning. They're not dead in the water. And as a result of that, in the cluttered closet, we open up the closet door and go, whoa, this is completely inefficient, but it's working. I could shut the door and a closet's still working. So what I need to do to straighten it out and make it more efficient is I first have to unpack it. And when I begin to unpack it, just at that moment, my wife, Nancy, walks by and she goes, what a terrific mess you've created. And I'm going, no. I've got a bigger plan. I'm going to actually take it all out and then put it all back in. And in that moment of the second scan, many times we're capturing that moment of good intention of unpacking. And as we begin to repack and reorganize and get back into this next one, we start to see the patterns improve, the percent of the pattern come up. And so I want you clearly to not judge yourself or not let your patient judge you, or for you to judge the patient in the second scan especially. Typically by scan 3, if we're on 12 visit cycles, we start to see this repackaging into a more organized way. If not, well, you're right in the middle of continuing repacking. Remember, before we start judging ourselves in care planning or otherwise, we need a 3-scan model. Initial, progress, which can show changeability, which I'm showing here. But by the time we do scan 3, we want to start establishing trends. Are they still trying to unpack, or are they starting to reorganize? This is the principle of salutogenesis. You're either moving towards a more balanced and coherent state, or you're moving or trying to get back and you're falling behind. And so keep that in mind. Recruitment of new neuromuscular connectivity is what's happening when you see that sort of scan 2 being worse. Note to yourself, sometimes scans look worse in a good way because you are observing neuroplasticity. So let's get on with it and do some adult case studies. These will go quite quickly. So for those of you that have been really putting yourself into this position of listening and learning, this was where it will all come together. And as a consequence of that, we're going to take the same case studies that we had from the HRV, but now we're focusing on the EMG parts to them. So again, remember on the left, we're looking at the amplitude, and this is the bar graph. And so the bar graph represents what we see many times on the pattern graph. And so these two then combine along with the thermography and the HRV to produce a core score. So in this first initial study, let's take a look at that. So what should catch your attention in this area is obviously the areas under stress, but the grouping of this is particular in the cervical spine. And what did we say that was associated with? Keep your eyes posturally on forward head carriage. This person scored a 67 on the overall energy management of there. And that allows us then to start taking, that's their overall score on the EMG. And that's a combination of their symmetry and amplitude. And you can see why they were a little bit above, I would say at the average point, because there's a lot of normal ranges, but they lost their scores, especially in that cervical spine. and that one jolt that was associated in and around the T10 region. And if you are and you're starting to see a asymmetrical unit like that, a motor unit like that, there are two things you might want to do. You might want to remember that while scanning, if you get to see an aberration like that, it's okay to redo that segment and see if that was a user error. I'm assuming that since I know these examiners that was not a user error, and so this is a good one to reflect on, that it was an isolated, myomere that was very much active. And it could be where the primary subluxation is. We'll have to look further. You'll notice that the three scores on the bottom is that this person is spending 165 in their energy index versus 100, and that's all being lost in that cervical spine primarily. Their pattern in their efficiencies is pretty good. It's at 77%, which, as you can tell on the, there's a lot of good distribution, especially as we go down that mid-thoracic right to lumbar region. And the symmetry is not so bad either. It's at 68%. I mean, I really think that if we took out that T10, that symmetry would go high into the 80s. We're looking at that whole region as being influential. So good starting point. And we're looking at the EMG. So now we take a look at scan 2, and I always like to do this, is go back and just reflect on that. And I've added a third scan, which is the shear plan, the postural balance, and these are where you're looking at shear forces. And so again, taking a look at, and I'm going to flip backwards one more time, keep a look at that initial cervical grouping. You'll notice that it is involved in each level. And as we go to scan 2, it's breaking up. We're starting to see some normative areas coming back in. It's costing a little more at the C7-T1 area, but you'll notice that region in T10 is completely reacting and shifting differently. Very interesting. Maybe that is the primary. Again, we've put a lot of change in, and so the pattern is now shifting from 65% down to 55%. We're okay with that. Symmetry is again being shocked. But look at the energy index. We're starting to regain some of the energy from being 165 dropping down into that area. A lot of shear responses going on the right-hand side, but we're in the early changeability of this person. Taking a look now, and we're starting to see that we've got a very interesting phenomenon occurring. This doesn't happen very often, which is why I chose this scan sequence. You'll notice that they're now spending a lot of energy. It's coming down from the double reds, if you would, on the cervical thoracic region on the left-hand side, but there's still this persistent forward head carriage. Now, that's not surprising. This is only a couple of months down the way, but look at how the body is now in an exhausted zone. It's exhausting to unwind these patterns. And the patient might be feeling that. This is really, this isn't, where we're talking about roses and unicorns. This is a big job to start unwinding it. And what you don't know about this history is that this was an injurious, long history of injury and a lot of scar tissue. And that's why the original ones were very much in the normative range, if you would. They were compensated. And so now we have on the pattern, we're dropping even on the pattern, and that's not a positive state. But what we know is that the patient is under our watchful eye. And so now we've got the pattern without those reactive regions in the T10 area. They've calmed down, and granted that we're a little bit on the low side, but the symmetry is coming up. And we're starting to see that there's this balance coming back in, and there are many less shear forces that are affiliated with it. And as we go into this region, we still see that we're struggling into this fourth scan region. But here's what you need to understand, is that the cervical spine is starting to really reorganize beautifully. And we're starting to see that when we start to look at the other scan scores, in this case, adaptability and thermography coming into it, that the patient has jumped overall in their neural profile from being a 65 core score when we started, I think it's 73 core score when we started, to now a 79. We're very excited to know that as we are reorganizing their postures, and the rest of their nervous system is again reorganizing to a higher state. And so one of the things that I think we need to recognize is that it's a absolute response to get back into this rhythm, if you would, of allowing ourselves the opportunity to manage ourselves and our patients. I think it's really important that we continue on, and we'll take a look at the deep dive in the child now. And this is good. This happens to be a 6-year-old as we start to go on. I showed you that we can do it on 12-year-olds, but remember I said 6-year-olds, you have to be very careful with when you're collecting with them. The pattern score with this one is difficult. It's 20. We've got a lot of reactivity that's going on. But generally speaking, what we see is that the lower part of the spine is in good symmetry. We've got a lot of difficulty in maintaining good head-neck posture, but we're still getting a usable scan that's coming up with this. And as we start to go down into the progress, we see that there's a much more definable region of activity. Probably the child is getting much more energized and active within their care. We're starting to see that tone in that cervical spine region is adapting. Now, one of the things that you need to know is that the energy index, especially in children, is very reflective of their behavioral state. Two things in play. One of the reasons I said that it jumps from the normative of being 100 in the energy to 125 is that there's a less adipose, if you call it, buffering that affiliates with that child, because they have less adipose tissues, so there's less signal attenuation. But when we take that into account, we also realize that children are very much in a very hyperreactive state many times through behavioral modeling. And so EMG is one of the hallmarks, especially in looking at children that are on the spectrum, to look at that energy score and start to see it. You'll see sometimes these energy scores in the 600s and 800s. This is critically important. There was an Israeli study that looked at, not necessarily EMG, but it looked at their HRV as it associated with energy and exhaustion. And it looked at a series of boys that were defined or identified as ADD, ADHD. And the number one thing that we could recognize in the study was that it associated with overall exhaustion. And one of the ways that children exhaust themselves is that when they're on the spectrum, they literally have to feel their way through their life and their environment. They can't process so much their behaviors and their emotions, as well as then their cognitions and even their sense of touch. Many times they're hyper responsive to touch. So when you see an EMG on a child, especially that has it having behavior, expect to see in the 400 to 800 range. We don't like to see that, but watch how it comes down, just like you're seeing on this one. And you'll start to see that this ability to come back into zone is short-lived many times, but it will come and go and come and go. And this is why EMG is such a critical tool. And you'll notice, this is the one that I love it. You'll notice that he went from an under 20% to, when we started to go down the care modeling, the pattern is now at 88%. Sure, lots of activity with energy being up at 230, but look at that pattern and look at that symmetry. This is why you want to have symmetry and pattern affiliated and not just look at this amplitude bar graph and go, oh, there's a lot going on. Yes, there is, but there's a lot of change and a lot of improvement. So one of the things that I love to do is sort of lead ourselves into the next relationship and next part of it. We set up a 3-part deep dive, and that 3-part deep dive was primarily affiliated with looking at what we call the RED sequence, R standing for reserve, and that's why we took a look at pulse wave profiling and the HRV as our starting point. We wanted to then look at energy and exhaustion that associates with the EMG. We've just finished this one. And we then want to take a look on the next one of looking at the depth of change of the neural dysfunction or reorganizing function by looking at thermography, which tends to look at the regulation of the end organs, if you will. So by the time we've created this idea of looking at the reserve, looking at the energy expenditures, and now we're setting ourselves up to look at the depth of change, we have the ability to understand the impact of vertebral subluxations, but most importantly, adjustments on the health and life of the patient.